Well, thank you all for coming, especially thanks for Professor Petit for his very kind words. I'm deeply touched by what you said, and I've been also I'm very grateful to him for all the support that he has provided to me and to our research group, and also in helping us to integrate with the APA, with the scientific community here at the United States. So, and also for the opportunity and the honor to be here at Harvard to meet some colleagues and also to discuss some partnership and also to share some ideas and research with you all. Thank you very much. What we will try to do now, we will present briefly the World Psychiatric Association position statement, and also we will try to illustrate it regarding research and clinical practice. And to illustrate, we will present briefly some of the studies that our group has done in Brazil. So we will do both things. We will present the W position statement and also present of some of the work that our research group in Brazil has performed in this field. And we hope in the end we'll have plenty of time for also for discussion, interaction, and things like that. So this is the position statement. It was approved in the end of 2015 and was published at the World Psychiatry 2 years ago. It's the World Psychiatry is the journal from the WPA. It's open access, and also below you will have the website of the WPA section on religion, spirituality, and psychiatry, where you also can find the position statement. So I will show basically all the position statements. It's only 2 pages document, and I will just highlight some of the main aspects of this position statement. So it starts saying that the WPA and the WHO are committed to a comprehensive mental health care promotion, care, and also a scientifically based care. This is essential. And also a care that is at the same time evidence-based, but also compassionate and culturally sensitive. And exactly because of that, it's the importance of taking into consideration religion and spirituality. We have now some systematic reviews like the Handbook on Religion and Psychiatry and Mental Health, Handbook of Religion and Health, edited by Harold Koenig and other colleagues in the 2 editions. They have systematically reviewed more than 3,000 empirical studies on health and spirituality, and about 8% of these studies are on mental health. Okay? And we have now strong data showing that religion and spirituality of people, of patients, have significant implications for the prevalence of mental disorders, especially substance use and depressive disorders, for the diagnosis, for example, differential diagnosis between health spiritual experience from psychotic disorder, for example, people hearing voices, having transcendental experience and things like that. Also, there is a lot of implications for treatment about spiritually integrated psychotherapy, mindfulness, the help-seeking behavior. There is also a strong impact on outcomes, like in recovering from depression, and also, for example, in suicidal deaths. As Professor Van der Wiel is here, I will also present his study here showing a huge impact of religious attendance on suicidal deaths. There is also implication for prevention, quality of life, and well-being. However, that as we see here, the Star Wars, there is always the dark side of the force. So we have the bright side of the force and the dark side of the force. So we have also the negative aspects of religion and spirituality. It can fostering prejudice, it can foster isolation, it can also promote negative religious coping, and that all of these have also negative impacts on health. But it's good to know that most of the religious coping is positive. Most of the time, people use religiosity and their spirituality in positive ways. But of course, we need to be aware of the negative use of spirituality and religion as a whole. And there is also another important aspect. Most of patients who have studies, for example, from the United States and from Brazil, show that most of patients would like that their clinicians address their own spirituality and their religiosity. However, most of the time it has not been done. So we have quite a gap. Nowadays, most of clinicians are aware of the importance of spirituality. Patients would like that it should be addressed, but in the actual clinical encounter, it's not done. So this is one of the reasons for the position statement, to call about the need for a better education of clinicians, of psychiatrists, including more of these variables on research and also take this in consideration in clinical practice. Just to present some world data, about 86%, not about, 86% of the world population is religiously affiliated. That means that 6 billion people in the world has some religious affiliation. So we are talking about the vast majority of the world population, and also, so we are saying that something that's shared by most of the world's population impacts health. So it must matter to us that are clinicians. It's not a matter if I'm religious or not, if I like religion or not. No, that's not the point. The point is what is important to health outcomes and to well-being of our patients, and we need to be aware of this. It doesn't matter if it is sexual life, if it is financial issues, the social environment, or religiosity. We need to take this in consideration. And even regarding some religious beliefs, for example, very prevalent religious beliefs throughout most religious traditions. For example, the idea that people have a soul or there is life after death. As you can see here, the most populous country in the world, by large, most of the population believe that people have a soul and also believe in life after death. Here, the only exception we see here in life after death is Russia, okay, regarding the most populous countries. Unfortunately, we don't have that data from China, because at the World Value Survey, China is part of it, but these questions are not available about China, so we don't have the data about them here. Okay, so these are the 2 editions of the Handbook of Religion and Health that by Hart show make us a very in-depth, comprehensive, systematic review of the empirical data on this field, and we will now illustrate some of this data, some of these findings with our own data. And also regarding this more than 3,000 studies, here we perform an analysis at Scopus database, seeing what countries have published the most regarding spirituality, religion, and health. Okay, and we found the first country is United States, the second United Kingdom, Canada, Australia, and then Brazil, Germany, Iran, India, Israel, and the Netherlands. So it's Brazil in the general scientific output in all areas is in 13th place, but regarding spirituality and health, Brazil is in the 5th place. So it is a growing area in Brazil, so I will present briefly some topics regarding to this. And specifically regarding spirituality and health in Brazil, most of publications come from psychiatry, okay, and also about public health, general medicine, and also have nursing. This is an interesting topic. In most of countries, in the world as a whole, most of publications come from medicine, and then from psychology, and then from nursing. In Brazil, it's medicine and then nursing. Nursing is the second large area of clinical practice related to that. So we have a lot of things related to public health, general medicine, psychiatry, and nursing in this area. So this is one of study of our group. This is a study of 168 bipolar outpatients. Okay, so we try to investigate how much religious involvement influenced their levels of depression and their quality of life. This is the first part of the study. This is the cross-sectional data. In this cross-sectional data, we found, for example, that patients, bipolar outpatients, who had high levels of intrinsic religiousness had 5 times less depression than those with low levels of intrinsic religiousness. And also, we could see here in the quality of life, we use the Huckwall scale for quality of life, that, for example, the intrinsic religiousness was related to all levels of quality of life, physical, psychological, social, and environmental. However, the negative religious scoping was inversely related with psychological well-being. That means the higher the levels of negative religious scoping, the worse the psychological well-being. Another aspect of the dark side of the force is religious disagreement regarding treatment. We had that about 30% of patients report some kind of religious disagreement towards treatment. As we know, and we know in bipolar patients, this is quite an issue sometimes. Patients stop mood stabilizers, for example, because of religious things. Some their priests could say something against the treatment. And here we have the longitudinal data of that sample. We have a 2-year follow-up of that patients. And what we found here basically was that the patient, the sample as a whole had a good improvement in depression. So most of patients were euthymic. So we didn't find any more a correlation between religious involvement and depression, probably because of kind of Fora effect, since we had very low levels of depression in the sample. However, we had a very interesting data regarding quality of life. As we know, full recovery of patients is much more than just having no psychiatric symptoms. They can have no depressive symptoms, but they cannot be working well. They cannot be having a good quality of life and things like that. So this is exactly what we saw here. We can see here that despite these patients are euthymic, they had quite a difference in quality of life. So what we saw here is that especially the positive and negative religious scoping in the beginning of the study was a strong predictor, was strongly associated with the levels of quality of life 2 years late. So as we could see here, for example, the positive religious scoping was associated with about 10 points more in the quality of life scale, the Hucol scale, 2 years later. But the negative religious scoping was associated with more than 20 points less in quality of life scale. So as we can see here, despite the patients having no depression, no mania, they had large difference in quality of life, in the full recovery. So as we can see here, the religiosity could have association with positive outcomes, but also with important negative outcomes. And here, the effect size of the negative outcome was even higher. However, as I said previously, the positive religious scoping was much less frequent than the positive religious scoping. It's about 1 to 3, 1 to 4. Okay? So this is one data. The other area, perhaps one of the areas that has more studies on spirituality and health is regarding drug use and abuse. Okay? This is a national sample of 12,000 university students throughout the country and in Brazil, and we found basically that people who are actively involved with their religious affiliation had about half of the chance of using legal or illegal drugs in the last 30 days. So this finding has been replicated in many studies, in many areas, in many countries also. This is a more recent study. We have just submitted this publication. In Brazil, we have a terrible epidemics or crack use. Here you have opioids, there you have crack use. Crack is a very terrible problem that we have in Brazil nowadays. And we investigate a quite large sample of crack inpatients, crack-dependent inpatients, 500 people. So that means that they had severe crack dependence, okay? And we investigate how much their religiosity in the childhood and adolescence could have any connection with the severity of their crack dependence in the current time in hospital admission. One limitation of this study, of course, is because of memory bias, because we are using their reports during hospitalization about their previous religious attendance in childhood and adolescence. But what we also now are doing a follow-up of these patients after hospital discharge. But what we had here is the following. If we compare, for example, the frequency of the religious attendance of this crack dependence during early teenagers, we had no significant association. But when we saw here a bit later, from 15 to 17 years old, we had that the children, the patients who attended religious service during that period, probably the period that's more of more risk to start using drugs, 15, 17 years, they had half of the chance to have started the drug use before 18 years old. They had half of the chance to have high levels of use, more than 10 crack rocks per day, and also they had lower levels of craving. So these are some data suggesting that some levels of religious involvement, especially during teenagers, it's related to less severe crack dependence. So we are discussing here, different from the previous study, because as we know, people that are more religious involved, they tend to use less drug and they have less chance to become addicted. But since they became addicted, this is the group that failed, this protection failed, they, despite that, had a lower, less severity of this dependence. This is another study with a 1,500 sample of elderly in São Paulo, in a poor neighborhood in São Paulo. And it's, we investigated here the prevalence of common mental disorders symptoms. Actually, basically depression, anxiety, and psychosomatic symptoms, okay? And we found in this sample that the elderly of these poor communities in São Paulo city who attended the church had about half of the prevalence of common mental symptoms than the others that did not attend. And we tried to control and to see if this positive effect could be associated or mediated by social support. Because one of the major challenges that we have nowadays in association between religiousness and spirituality and mental health, we have a lot of data showing that there is association, but the question is, one of the big questions is, what are the mediators? What are the mechanisms? And one of the possible mechanisms is exactly this, the social support. And here we tried to test this. For example, the support related to friends, to neighbors, contact of relatives, and also if they offered support, if they were saw as resource in the community. And after controlling for all these social support measures, basically there was no change in the association. So it suggests that this association between religious attendance and better mental health does not seem to be mediated by the secular social support, at least. Perhaps something specific exists in the religious social support. So this is the study from Professor van der Wiel, a recent study that's a kind of landmark study showing the importance of religious involvement and the impact of this on health. This is a large study, about 90,000 people were followed up for 14 years here in the United States. And they investigated if religious attendance predicted lower deaths by suicide, and actually it did. As we can see here, we had basically a 6-fold decrease in the comparing people who attend once or more per week with people that never attend. So it's a sharp decline. We basically have few, if any, predictors so strong as this, and also trying to test the possible mediators of this association, since religious attendance is related with better social support, is related with less alcohol drug use, and with less depressive symptoms, they controlled, they adjusted for all this stuff, for social integration, alcohol, depression, and guess what? Basically, there was no change. So that's, again, the same message. Attendance is related to a sharp decrease in suicidal deaths, but it does not seem to be mediated by social integration, by depressive symptoms, or alcohol use. So we need to look further for other mediators. This is one of the most challenging areas that we have nowadays. Okay, this is, and now moving also to another aspect, a more positive health, and positive psychiatry, investigating not only, as we said previously, a decrease in depression or a decrease in drug use, but also an increase in quality of life and increase in happiness, well-being, and things like that. So this is also a study that we have just submitted. This from one of PhD students of us, Janaína Siqueira. We investigated 161 hemodialysis patients. We know people under hemodialysis, they are facing severe challenges in their lives because of the limitations caused by the disease, by the treatment, and things like that. And we try to investigate the happiness. What would be the predictors of happiness among this sample? The first thing that was really surprising to us was that all these gender, age, education, and also the physical aspects of health, like the number of comorbidities, like hypertension, diabetes, the number of years that they have been in dialysis, the level of hemoglobin, and even the KTV, that is an index of the quality of dialysis. All these parameters were not related with happiness. It was surprising to us, but they didn't. In the same sense, also the organizational religiosity was also not related. Perhaps because these patients, they have some severe physical limitations, what impairs their skill, their abilities to go to church, but private religiosity and intrinsic religiosity were associated with happiness. And also we try to see about sense of coherence. The sense of coherence, it's a construct from salutogenic perspective. Basically, it is an outlook, how people see the problems that they face, if they see these problems as challenges, as opportunities to growth, and things like that. So these three variables were related to happiness, but the physical aspect of health and the organizational religiosity was not related. We are now analyzing data from the 2-year follow-up of this sample also. Okay, let's move. So we just presented a broad overview of several different ways in which religiosity and the spirituality could impact the prevalence and the recovery of mental health or mental disorders. But also, let's move to another aspect regarding conceptualization. We know that it's lacking a universally agreed definition of religion and spirituality. It has been discussed for many years. We don't have a consensual definition. However, we stated here that spirituality is in some sense related to the transcendent, the sacred, and the ultimate reality. So this is usually what is mostly understood as the core of spirituality. It's related to transcendent and the sacred. And also it's related to meaning and purpose in life. There are some debates on that. I will present this in the next slide. But it's related, but it's not necessarily the same of meaning to life and purpose. And religion is the institutional aspect of spirituality. It's usually a system of beliefs and practices shared by a community. This is the religion. And the world population, most of the spirituality is lived inside a religious community. Okay? Despite it's growing the number of spiritual but not religious, but by most of the population, they come together, religion and spirituality. And specifically regarding this, the definition, there are several discussions on this. And Herbie Koenig and I, we published a a discussion paper exactly about the meaning of spirituality. One of the problems and our concerns is that several concepts and measures of spirituality contain questions about psychological well-being, satisfaction with life, connectedness with others, hopefulness, meaning, and purpose in life. We think that these are very interesting constructs. We think that they can be the outcome of religious involvement of spirituality, but they are not exactly the same of spirituality and of religiosity. And the main problem of using measures of spirituality that involve this kind of questions is the tautology. Because if I measure spirituality as feeling in peace, in having purpose in life, in feeling well, and if I try to associate this with some measure of quality of life or of depression, I will always find an association because these concepts are already included in my measure of spirituality. So several studies have this flaw. We need to be very cautious about that. But it's there is a big discussion on this, okay? We can discuss later if you'd like. Okay, let's moving forward for the position statement. And so, regarding this, despite this, religion and spirituality, it's important, a consideration of their relevance to the origins, understand the treatment of psychiatric disorders, and also the patient's attitude, and should be central to clinical and academic psychiatry. So, we have now some recommendations from the position statement. The first one is that patients' religious and beliefs and practices should routinely be considered in history taking, and sometimes it could be essential part of it. So since religious and spirituality is something very prevalent, since it's a very common coping strategy, it's important to take this in consideration and consider this in our patients in basically all history taking. But there are some barriers. There are some barriers to integrate religion and spirituality in clinical practice. This is a paper published by some colleagues of us in Brazil. It's a national survey of psychiatrists, and what they found that the most frequent barrier that they declare is the fear of exceeding the role of doctors, 30% of them. Lack of training, 22%, and lack of time, 16%. So, as you can see, the two major barriers are the fear of exceeding the boundary issues, and the second is the lack of training. But it's very interesting if you see that if they consider important to integrate patient spirituality in clinical practice, almost 8% agrees. However, as you can see, the religious affiliations influence. Psychiatrists no religious affiliation, about half of them, but almost 90% of those that has religious affiliation agrees that's important. However, the religious psychiatrists, despite they think it's important, they are more likely to report the fear of exceeding the role of doctor, 36% compared to 17%. So this is very important. So they are aware of the importance, but perhaps because of the lack of training, they are fearing regarding boundary issues. It's of course it's something very important. So it call our attention to this, to the importance of a better training or better knowledge about this topic. And exactly because of that, several authors in the field have tried to provide some kinds of continual medical education on this. At the APA this week we had several sessions on spirituality, on psychiatry, and discussing different aspects. We also have published some guidelines, also in partnership with Herdo Koenig and another colleague, Giancarlo Luchetti from Brazil, about some guidelines in how can we integrate spirituality to clinical practice. The first and foremost important thing is it's patient-centered. It's not prescribing, not imposing. Not imposing religious perspectives, neither anti-religious perspectives, because this is also another problem. Several religious patients complain that during their psychotherapy, their clinical encounter, they were dismissed in their religious affiliations, beliefs, and practices, or they received some no respect non-respectful commentaries or interpretation of their religious commitments. Okay, so we need to take in consideration what's important to the patient, not for us as clinicians. We need also to pay attention, of course, we pay attention to spiritual issues, but we not neglect the physical, the mental, and the social aspects. So we need to have a very quite open-minded approach with genuine interest for the patient as a whole. That's basically the major idea. And the most agreed intervention regarding spirituality in clinical practice is taking a spiritual history. And also these colleagues performed a systematic review of the instruments available for clinical use of spirituality. And according to several criteria, the best was the FICA. The FICA is just a 4-question questionnaire that's very easy and very fast, very quickly to be used. 5 minutes, 4 to 5 minutes only we can use. So this is one of the best strategies. If you'd like to have a more deeper interview, the Royal College of Psychiatrists provide also a very good questionnaire providing an in-depth and deeper evaluation of patients' spirituality. And there are some studies showing that just by taking a spiritual history, 2 or 3 minutes is associated with the patient's rate higher the quality of the treatment. Probably because they felt better understood and saw as a whole. Okay, other topics. Also, it's essential also to understand the impact of religion and spirituality and their relationship to diagnosis, etiology, and treatment of psychiatric disorders. Especially regarding the differential diagnosis between some depression or some religious issues, some difficulties that they have, as I said, some psychotic disorders and things like that. The need for more research on clinical applications. This is one of our major challenges. One of the major challenges, the mechanisms. The second major challenge is the clinical implications. How can we translate this knowledge to the clinical practice? And also that higher diversity of cultural and geographic backgrounds of study. And as I said previously, the approach must be person-centered. So some studies about the differential diagnosis. One of the major things nowadays in this topic in religion and psychiatry is about psychotic experience and hallucinations. We used to learn in our psychiatric training that hallucinations are indicative necessarily or almost necessarily of a psychotic disorders. However, many studies nowadays, this is an international study by WHO with 250,000 people around the globe, showing that 12% of the world population reported some psychotic symptoms in the last year. Okay, usually hallucinations or things like that. And these hallucinations not during that period in the transition between sleep and the waking state, and also not related to drug or substance use. Okay, and what's very interesting, only 1 in 10 of these people had actually schizophrenia. So that means that basically 90% of people having psychotic experience are not psychotic actually. This has been well replicated nowadays. That we must understand this non-clinical population that have psychotic experience or anomalous experience. It varies the name that we give to these experiences. And one of the best places to study non-clinical samples that has high level of this experience are religious groups. Quite often they have people having this kind of experience. And it's also very important to avoid some iatrogenic effects. Especially in the end of 19th century and early 20th century, it was quite prevalent in Europe, US, and also in Brazil, a very negative perspective of psychiatry regarding these spiritual experiences that involve in trance, hallucination, and things like that. This is the history of spiritist madness in Brazil. For example, so we showed that most of the leading psychiatrists in Brazil, but also even here in the US and also UK, tended to consider religious experience like this as a strong sign or a risk factor for mental disorder. Actually, there were several movements to change the laws to forbid these religions here in the US, in Europe, and also in Brazil. Okay, so we need to be aware of this. And so we did a study with 115 spiritist mediums, spiritualist mediums in Brazil. So these are people who have high levels of hallucination. They see things, they hear things, they report that they have thought insertions caused by spirits, by deceased people, and things like that. So we investigate these people that have been working in these spirit centers for many years. Okay? And what we found, they actually had high levels of psychotic and dissociative experience, high levels of even first-rank symptoms for schizophrenia, Schneiderian first-rank symptoms for schizophrenia. They had on average 3 of these symptoms. However, they had a low prevalence of common mental disorders, of anxiety, depression, and psychosomatic. So, and also we investigated, they had good levels of social adjustment. Actually, contrary to what we had expected, the higher the frequency of full trance or auditory hallucination, the lower the prevalence of anxiety and depression, and the better the social adjustment. So it goes against the idea of a continuum of psychosis. Some people would have a few of psychotic symptoms, they will be more or less, and the more they had the symptoms, they would become more psychotic and more disturbed. Here we have a group that have high levels of this experience, but are functionally very well. Okay? And all these people, just to make sure, in Brazil, the mediums, they do not work as mediums in terms of make their living of this. This is always a charitable enterprise. So they have their regular jobs, and they work as mediums as a volunteer thing in their religious groups. Okay? So they have their regular lives. So, and because of that, we have discussed several ways in how can we differentiate this. In a partnership with Puerto Rico, how they integrate this, and also in African Brazilian religion, how can we use the DSM-5 if it can or cannot help us in this, make this distinction. One of the major findings that has been that has appeared in these studies is that if the person starts to have these experiences, and if they don't have a cognitive framework that makes sense of this experience, and if they don't have a community that's supportive of it, even if it's non-pathological experience, the person can have, that can be stressful, it can be very hard to them to cope with this. So this is what we can find in some of the case reports when we do in-depth analysis of the life of these people. So having a cognitive framework and a resource community that could provide support to them is something really very important. Because otherwise, the usual cognitive framework is, I have 2 options. I'm crazy or I'm under demonic possession. Neither is a good option. So it's very stressful for most of it. I'm telling this because this is exactly what we found in qualitative interviews with these people. When they told about when they started having this experience before they were integrated in another community. And exactly because of that, we started another study, a longitudinal study, of also 115 people who seek the help in these spiritist centers in Brazil, exactly because of this psychotic anomalous experience. Okay, so the previous sample was of people that were well trained, that have been involved in this for many years. Now we have a different sample, people who start having this experience and seek the help. So they were disturbed by it and seek the help, but seek the help not in the medical community, but seek the help in the spiritist centers. So what we found here, it's interesting. We found a high level of anxiety disorders, not of psychotic disorders. We had some psychotic disorders among these people, but the most prevalent were anxiety disorders. Exactly because they were afraid, they did not understand what was happening, and some of their experience, we try to use the names that they call their experience, Clairvoyance would be kind of visual hallucination, auditory hallucination, some more unspecified perception, some kind of precognitive dreams, out-of-body experience, precognitions during their daily life, and things like that. So these are some of the very frequent experiences that they had, okay? And we did a 1-year follow-up of these people. We investigate especially, we did in partnership with Robert Cloninger from Washington St. Louis University, and also Gordon Clegg Miguel Farias from Oxford. It's the PhD of Letícia Almiana. And we investigate some personality factors that would predict a better quality of life. This is the cross-sectional data, the initial data, the cross-sectional, about the quality of life and personality traits. What we can see here is very interesting. Self-directedness, it's positively related with better psychological quality of life. This is very important. The self-directedness is, and will be, as we'll see later, a good predictor for a better outcome. And as we can see here, the unusual experience, that's exactly hearing things, and the unusual experience was related only to the environmental quality of life. Exactly this feeling different, feeling isolated. The other dimensions of quality of life are not related. This is one thing that we'll show later. One of the best, put it another way, a way to differentiate a non-pathological spiritual experience like hallucination and a pathological hallucination like in schizophrenia, psychotic disorder, we should not put so much emphasis in the positive symptoms like hallucinations, for example. We should put more emphasis on negative symptoms, disorganizations, cognitive symptoms. Because several data have shown that specifically the positive symptoms like hallucinations are not good discriminants between the healthy and unhealthy experiences. As exactly what we see here. But as we see here, the introverted anhedonia, that's a kind of negative symptom, psychotic negative symptom, is also related with worse psychological well-being. And also harm avoidance was an important predictor in a negative way. It's in that cross-sectional data. But regarding the longitudinal data, as we had said previously, after 1 year, cognitive disorganization was the predictor of worse quality of life, and self-directedness was predictor of better quality of life. The frequency of unusual experience was not related. So again, it tells us a lot that we should not put so much emphasis in the positive symptoms and put much more emphasis on these other psychotic symptoms, like disorganization, negative symptoms, and things like that. Exactly based on all these kind of studies, we propose some guidelines, and we are in the working group of ICD-11 exactly in make the distinction between spiritual experience and psychiatric disorders. And some of the criteria, these are some criteria that are suggestive, that can help our clinical reasoning in making this distinction. One is the absence of psychological suffering, absence of social impairment. However, as we said previously, the social impairment and the psychological suffering can come if they don't have a cognitive framework or a community that supports them in this experience. But one of the most interesting aspects is exactly the absence of psychiatric comorbidities or other symptoms suggestive of psychotic disorder beyond just that specific experience that they are having. This is one of the most important aspects. And of course, what is the outcome? Sometimes the dark night of the soul, it's very productive. It can bring a flourishing. You can flourish, you can grow through this. Okay, and also regarding this spiritual experience, we have performed some neuroimaging data, the neuroimaging studies, functional neuroimaging. This is a study that we performed in partnership with Andrew Newberg. At that time, he was at the University of Pennsylvania. And what we did here, we investigated people that during trance do automatic writing. They do some automatic writing trance and attribute this writing to spiritual entities. Okay? What we did, we compared their brain activation and what they wrote and the content of their writings we compare the trance writing with the control writing. The control writing is the regular writing in regular state of consciousness. Okay? What we found was the following. The outcomes, the data were different between the most experienced and the less experienced mediums. Among the most experienced mediums, during trance, they had texts that were more complex than the usual texts in the regular state of consciousness. But despite writing a more complex text, they had lower levels of activation in several brain areas, specifically some prefrontal areas related to cognitive effort and to discourse organization and things like that. So it's a quite interesting finding that because despite writing a more complex text, they had lower brain activation in some key areas in frontal and prefrontal area. This is also a more recent study. This is a functional neuroimaging study, also of this kind of psychotic-like experience, but our spiritual experience. We asked them, this study was performed in Germany. We asked the mediums to enter in trance inside the fMRI scanner, and they had several experiences like seeing and hearing spirits, according to their claim. They had out-of-body experiences, and also they claim to have perceived other people's thoughts and things like that. Okay, and we compared them with 8 controls. Okay, and basically they were matched. They did not differ actually regarding neuropsychological and psychopathology tests, and also the resting state network. It was quite similar. And what we did here, we compared. We asked them to first to rest, the resting state. The second, they enter a trance, and the other, they will try to relive in imagination their trance. Okay, we try to see the levels of brain activation. So one point is, when we see the red ones is when the trance is higher, the areas that are more activated in trance than in rest. These are basically areas related to sensorial perception. What is in line what they had claimed. They had claimed that they saw things, that they heard things, and things like that. And regarding, no, this is the blue ones, I'm sorry. And the red ones is the trance, I'm sorry. The blue ones, yeah, the blue ones, trance versus control. The control situation is then when they imagine the situations. So we could see here, for example, in the occipital lobe, because exactly of their quite vivid perception that they had during trance, they had higher activation in occipital lobe, for example, compared to the imaginary state. And also they also had some other activation in posterior cingulate gyrus, also relate to some sensorial perceptions. So they claim a very vivid perception during trance, so it's correlated with actually a higher activation of these sensorial areas in their brains. And this is also interesting because the resting state and also the connections that we measured in the resting state were preserved among these mediums, different for schizophrenic patients. When compared with schizophrenic patients, they have some disturbance in this integration of different brain areas. So it could be one of the reasons why the mediums are healthy and the schizophrenic patients have problems, perhaps because of the integration of their brain areas. Moving to the end, to open the floor for the discussion. Also, our group have done some studies about mind-brain issue. It's some way related to spirituality also, because usually the spiritual people, religious people, they tend to have a non-materialist perspective of human beings, of human nature, and we also have done some of this. This is a study that was supported by Templeton Foundation through a grant from Oxford University. And we investigate, for example, among Brazilian psychiatrists, 600 Brazilian psychiatrists, we asked them, do you think that your mind, our eye, is a product of brain activity or is something beyond that? Okay? And it's quite half and half. So half of psychiatrists believe it is a brain product, half think it's not. And also, do you think that the universe, everything that exists, is composed only of matter? And about 70% disagreed with this. So this is just and some data related to that is also has been found among physicians in Europe, also something similar to this, half and half. And also there is another study about philosophers, top philosophers especially in Australia, Europe, and the US, about 40% would endorse this. And also we finished recently, also it's published ahead of print, a paper about the mind-brain problem in the leading psychiatry journals. We investigate how the 3 major general psychiatry hospitals, the American psychiatry journals, American Journal of Psychiatry, German Psychiatry, and British Journal of Psychiatry, how they covered the mind-brain problem in the last 20 years. Okay, this was what we did. This is also a partnership with Robert Ploringer. And what we found, they published very few papers on this. Only 23 papers provide an in-depth discussion in 20 years in these 3 journals about this. However, these papers has been published by many high-profile authors: Eric Kandel, Ken Kendler, Gan Gabbard, Udovsky, so Aaron Beck, Thomas Insel. As you can see here, all the big names are involved here in this discussion. And also, they had high levels of citation. On average, 100 citations in the Web of Science on average. So very few papers, but written by very well recognized authors that received high levels of citation. However, what we found was there was a lot of misrepresentations of the mind-brain problems in the leading psychiatry journals. One of the most common misrepresentation is about the Cartesian dualism. It's kind of straw man strategy. Quite often it's said in these papers that Descartes said that, but actually he said exactly the opposite. For example, Descartes said that the brain is completely separate from the mind. He didn't say that. Descartes denied psychosomatic, for example, that mind issues, anxiety could influence the body. So he said exactly the opposite. So there are several misrepresentations of several positions here, and we discuss all these topics. And another thing, for example, is that the non-materialistic perspective, the non-reductionist perspective is superstitious, primitive view, and not intellectually credible. A no-learned person would accept it. It's stating exactly like this. But the data, as I had showed previously, showed that it's not correct. And there's another data, for example, the idea that perhaps a non-materialist perspective of mental disorders of the mind would be the cause of a lot of prejudice and stigma regarding mental disorders. That if we just present mental disorders as a brain disorder, it will decrease a lot the stigma. However, there are 2 recent systematic reviews with meta-analysis showing exactly the opposite. The higher the endorsement to a strong biogenetic explanation of mental disorders, the higher the prejudice and the stigma. So basically what we present here is the need of a more in-depth discussion of this, and we recognize that this problem, the mind-brain problem, is still open, has not been solved. Perhaps it's one of the most challenging problems, philosophical and scientific problems, that we have in history, since ancient Greece. Exactly because of that, with a colleague that's philosopher and psychologist, historian and philosopher of psychology, we propose a kind of theoretical pluralism. We need to be open to discuss. We say that we, regarding mind-brain problem and this stuff, we are in a kind of pre-paradigmatic period in Kuhnian sense. We don't have actually a good paradigm that could explain mind, how mind connects to the brain, all that stuff, and mental disorders. So we need to be bold and to test different possibilities, different perspectives. Okay, one of good examples from a Harvard physician, philosopher, and psychologist is William James. We have some studies also in this philosophical aspects. William James proposed a radical science of mind, taking in consideration all human experience, not just a small range of experience. We need to enlarge our empirical base to allow us to move further. Like Charles Darwin, when Charles Darwin did a world trip in the Beagle, he was able to enlarge amazingly his empirical database. And though he was able to come out with a much better explanation for what is happening. Okay, this is, and what we claim is exactly that the in-depth studies of spiritual, different mystical, religious, and spiritual experience could be a very good database to enlarge our perspectives and to include, to take in consideration in our development. So this is a book where we edited with several different authors from different parts of the globe, from different fields, claiming and discussing the importance of spiritual experience for the mind-brain problem. And coming to the end, and psychiatrists should be willing to work with leaders and members of faith communities. It has been an increasing and growing aspect nowadays. And also respect staff and volunteers' spirituality. It has been shown that religious motivation for being physicians, psychiatrists, for example, seeing psychiatry as a spiritual calling is related to lower levels of burnout in profession, for example. And also, of course, we need to be knowledgeable about the benefits and also the harm of religious and secular and spiritual worldviews. So so we have also reviewed some things about the importance of faith-based health organizations to public health. The Lancet published a few years ago a series specifically called Faith-Based Healthcare, very important, claiming for a further investigation, especially in public health issues, the importance of taking in consideration the faith-based organizations, since they deliver a substantial volume of healthcare. However, there is a lot of prejudice in the scientific community and even the political instance in taking partnership with these parts of the world society. And let me just go to the... And finally, regarding the religious interventions, religious and spiritual interventions, this is also a meta-analysis published recently by some colleagues also from Brazil, showing the positive effect of religious and spiritual interventions regarding anxiety disorders, for example. And so, in summary, there are several reasons for integrating religion, spirituality, and mental health. First, most of the world's population has some religion and spirituality. And it's a very common coping strategy. Because of that, it impacts health, as we saw, for good and for bad. And addressing religion and spirituality and taking them in consideration in treatment may impact the prognosis, the outcomes. Patients usually want that clinicians address religion and spirituality. So it's a component of an integral and comprehensive patient assessment, and it's recommended by many medical health organizations, like the American Psychiatric Association, British Royal College of Psychiatry, the American Psychological Association, World Health Organization, World Psychiatric Association. So many organizations recommend this, so this is something that is very, very important. Also, in order to disseminate this knowledge, our group has created a YouTube channel, a bilingual YouTube channel in Portuguese and in English, with several discussions. Every week there is a new video, 3 to 5 minutes in science and religion. We have people from philosophy, from history, from psychology, psychiatry, discussing these topics. We have more than 200 videos that has been viewed by people from more than 160 different countries. So this is one source, if someone would like to take a look. And also, finally, these are our contacts. This is my email. This is the website. It's in English of our research group. And this is also the website of the WPA section, Religion, Spirituality, and Psychiatry. Thank you very much. Thanks for your patience.